I am speaking on Uroradiology covering Xray KUB and IVU. KUB here stands for kidneys, ureter and bladder. Xray KUB is very common initial investigation for urolithiasis and is complementary to ultrasound. Xray KUB is different from flat plate abdomen, which is done for bowel obstruction or perforation. The difference is that flat plate abdomen includes both domes of diaphragm done in standing position, and it's a PA film, whereas Xray KUB spans from top of adrenals to 2 cm below symphysis pubis, done in supine position and is AP film. For comparison, I have given both the films side by side. On your left side, you see X-ray flat plate abdomen, which shows multiple fluid levels suggestive of intestinal obstruction, and on right side is seen Xray KUB. You can see two films on the screen. In your left side, it is Xray KUB supine film. On right side, Xray KUB prone film, which is done sometimes for better ureteral drainage during IVU. But you can differentiate these two by identifying three features in the prone film. That is pointed iliac wings, short pelvic inlet, and magnified sacrum. Xray KUB is indicated in calculus disease before and after treatment. It is done as a preliminary film before any contrast film like IVU, RGP or nephrostogram. It is used to see the presence of residual contrast in previous imaging procedure. Also done to see position of drains and stents. It is sometimes done in blunt or penetrating trauma to the urinary tract, and also done before ESWL to see whether the stone will be seen during fluoroscopy or not. This is how you interpret and read Xray KUB. Name of the patient, date, position, exposure, bowel preparation, soft tissue shadows, bony shadows, and abnormal radiopaque shadows in this order. And each point in the subsequent section you will see separately. The first point is position. On your left side you can see that it is incomplete film, and on right side you see that if it is covering 2 cm below symphysis pubis, showing stone in urethra. In tall patients, even the biggest 14 by 70 film will not cover the whole KUB area. So in these cases, the Xray KUB can be done in two parts. After position, the second point is exposure. You can see that how overexposure leads to two black film without much contrast. You can see here that underexposure leads to too white and lacking contrast. This is the description of factors required for proper exposure for an average built patient. However, in obese patients, you need to have more than 80 kVps. You can see the bowel gases obscuring anatomical details. Bowel preparation for Xray KUB needs clear fluids for 12 to 24 hours and an enema 2 hours before the procedure. However, you need laxative in patients who are chronically constipated. This residual contrast from previous study obscures all the fine details In a properly taken film, you can see the soft tissue shadows like kidneys, liver, soft shadow, bladder due to low density fat which surrounds them, providing lucency. This is a plain film with beautifully outlined soft tissue shadows visible in this film. Bladder is outlined beautifully because of perivesical fat, and above that you can see little fluid in the peritoneal recess. Bilateral soft shadows are clearly seen in this, where absence indicates retroperitoneal fluid or mass. In this film, right-sided mass is displacing bowel shadow and obscuring soft shadow. This is a case of chronic retention of urine, possibly neurogenic. This is emphysematous cystitis with both intramural and intraluminal gas. The main content of gas is nitrogen. Gas speleogram in a patient with ureterosigmoidostomy. Emphysematous pyelonephritis with gas anterior and posterior to the stone. This shows an abdominal binder to be applied over abdomen before giving IV contrast, and once the pelvic calycia system is full, it is removed. On your left side, you see a film immediately after removal of binder, so that the full length of both the ureters is seen. Whereas without binder, if full length of ureters is seen, it is suggestive of some obstruction. There are certain contraindications to the use of binder, and one of these is gas under diaphragm. Another contraindication is green field filter. Abdominal aortic aneurysm is also one of the contraindications. In abdominal distension like this, you can't apply binder. Binder is also contraindicated in presence of any colostomy stoma. Bony details to be noted are fractures, reduced disc space, spina bifida, any lytic or blastic metastasis, any absence of vertebra or part of sacrum, and pubic diastasis. This X-ray shows spinal injury at the level of L1, L2. This shows fracture of transverse process of L2, 3, and 4 vertebrae. Fracture and disc space is always better seen in a true lateral film. Here you can see the fracture of vertebra in both films. Reduced disc space between L4-5 suggestive of prolapsed intervertebral disc. This is variety of spinal dysrhythmism. On left side you see spina bifida. On right side spina bifida occult. Normal intersymphysial distance is 1 centimeter. Now you can see as we progress from epispadias to bladder exstrophy to cloacal exstrophy, this distance increases. Due to marked pubic diastasis, it could be easily mistaken due to exstrophy. But normal penile shadow and right half of pelvis suggest open book fracture pelvis. This is classical butterfly fracture pelvis. This is sacralization of L5 vertebra. That means fusion of transpose of L5 to sacrum. Osteoplastic secondaries due to CA prostate. Osteolytic lesions in pelvis and upper end of femur. Sclerotic lesions in L1 to L3 from CA breast. Multiple lytic punched out lesions seen in multiple myeloma. Left side of bony pelvis showing coarse bony trabeculae, bone expansion and deformity suggestive of Paget's disease. This slide shows Potts spine with calcified source abscess in epi and lateral views. This is bamboo spine in ankylosing spondylitis. Two X-rays showing partial agenesis of sacrum associated with neurogenic bladder. Left side film shows subchondral erosion suggestive of osteitis pubis, and the right side film is after healing. Next point is calcifications. So we will discuss flavoliths, calcifications involving various organs and foreign bodies in these areas. Flavoliths are calcified thrombi in veins, rounded opicities with central lucencies and often confused with ureteric calculi. Causes of adrenal calcification are Emergencies, tuberculosis, cysts, neuroblastoma, pheochromocytoma, and METs. Adenocarcinoma pushing kidney down and the upper border rim calcification is seen. Left adrenal cyst with curvilinear calcification. Here is the list of dystrophic calcifications involving kidney, and the causes are many and varied. Let us see few. Curvilinear calcification at the lower border of renal malignancy. Large, simple left renal cyst. In adult polycystic kidney disease, both kidneys are enlarged with irregular outline. This is an X-ray showing calcifications in intrarenal arteries. This is autonephrectomy in renal tuberculosis. Any such rounded shadow with calcification should be investigated for renal artery aneurysm. On left side, another rounded shadow with calcification measuring 1.7 into 1.6 centimeter, which on right side eye view is outside the pelvic alveolar system. This on further investigation, that is angiography, was proved to be aneurysm arising from one of the branches of renal artery. Nephrocalcinosis can be cortical and medullary, and there are many causes. Let us see few. These are few pictures of cortical nephrocalcinosis. The causes may be shock, chronic glomerulonephritis, renal transplant rejection, hypercalcemia, and AIDS-related infections. This is dystrophic calcification after graft rejection. Here are few pictures showing medullary nephrocalcinosis, which may result from hyperparathyroidism, renal tubular acidosis, medullary small kidney, and hypercalcemia from any cause. Xray KUB and IV films showing early stages of medullary nephrocalcinosis due to medullary sponge kidney. Erect film showing layering of milk of calcium in a calcium diverticulum. Speckled calcification in bladder wall in GUTV. Bladder wall calcification in tuberculosis, amyloidosis, adenocarcinoma, and schistosomiasis. Bladder base and trigone are elevated, evident from the position of bilateral DJ stents. Middle portions of DJ are far too lateral, further suggesting tortuous and dilated ureters resulting from obstruction. Multiple calcific shadows seen in prostatic area in a case of localized CA prostate treated by brachytherapy. From the location and configuration of the organ, you can very well differentiate seminal-vesical calcification from prostatic calcification. This X-ray shows calcification involving the whole pancreas. Bilateral heavy costochondral calcifications obscuring fine details of the upper folds of both kidneys. Calcified right sacrotuberous ligament. Calcified bilateral sacrospinous ligaments. Calcified vas deferens and seminal vesicles. Calcified vas deferens and seminal vesicles seen in diabetes mellitus. This may also be seen in tuberculosis and schistosomiasis. Pelvic radiotherapy resulting into calcified iliac veins. Large calcification in uterine leiomyoma. This is how a pessary looks in a case of prolapsed uterus. Ovarian dermoid with teeth. Lost IUCD wandering in peritoneal cavity. This is how a tantalum mesh looks in X-ray. VP shunt in a patient with melangomyelocele and hydrocephalus. This is an X-ray showing position of artificial urinary sphincter. These are Fallop rings in a female after lap sterilization. Bilateral testicular implants in a patient after bilateral orchidectomy. There is an endless list of articles inserted into rectum. Here is vibrator. I think this is a toy car. Took a wrong turn and went into rectum. Upward migration and fracture of DJ stent. This is plain X-ray with two DJ stents. The right one is in CBD. Incrustation at the lower end of DJ. It's the legal duty of a person to remove the stent he has placed. Therefore, DJ stent registry should be maintained and patient should be reminded. And also it should be mentioned in the consent form that patient knows that DJ is in place and he or she will come for its removal. This image shows left DJ folded on itself and got entangled in mid-ureter. This probably resulted from pushing the DJ without guide wire in place. Leaving it in place for a week will cause passive dilatation, and thereafter you can try unfolding it without using force. Left DJ stent crossing midline in a patient with ILL conduit. This is AMS 700 penile prosthesis. This is an X-ray with colostomy bag in place. This is calcified granuloma after IM injection in gluteal region. The wire placed into bladder for sexual gratification. While describing any radiopaque shadow in KUB region, you should use prefix abnormal radiopaque shadow because bones are also radiopaque shadows seen in KUB area. Horseshoe kidney with left renal calculus. Only 10% of the gallstones are radiopaque, whereas 90% of renal stones are radiopaque. Gallstones can be differentiated from renal stones because of triradiate radiolucency, and these are never branched unlike renal stones. So at stone is you can get all types of stones. Before PCNL, calcified gallstone should be identified. Otherwise, for a moment, these may appear stone fragments migrated to upper calyx and tempting you to puncture gallbladder. Here you can see formation of column of stone fragments blocking right ureter, possibly after ESWL. The left side film shows a large vesical calculus, possibly due to neurogenic bladder, and the left side film shows a large vesical calculus, possibly due to neurogenic bladder, and the right side film shows multi-layered vesical calculus due to BPH. The patient moving with the stone after surgery. Multiple calculi in urinary bladder. This is end-on shadow of glans, mimicking stone in prostatic urethra. This patient actually came to me after negative cystoscopy. This is a patient with closed extrophy who presented with vesical calculus few years later. Multiple stones after ileocystoplasty. This is another X-ray mimicking the previous one, resulting from ingestion of soil due to anemia. This condition is called geophasia. And you can very well see that all these stones are in the descending column and up to rectum. Large stone in bladder diverticulum. Etiology of large bladder calculi includes bladder outlet obstruction, neurogenic bladder, formation around a foreign body, vesico-vaginal fistula with chronic infection, and cystocele. This is a patient with prosidentia. The left side film shows ring pessary to reduce prolapse, and right side shows large calculus in associated cystocele. Two X-rays showing impacted large ureteral calculi in females. These abnormal radiopaque shadows appear to be female urethral calculi, but from the last film it is evident that they are the stones in urethral diverticula. Impacted urethral calculus with retention of urine. Ureter courses along the tips of the transverse processes to pass in front of sacroiliac joint and moves laterally to ischial spine before turning medially. Now this is evident from the course of a DJ shown in this X-ray. Any abnormal radiopaque shadow along this line is suggestive of a ureteric stone.
Now, ureter can be divided into three parts. The upper ureter extends from UPZ to upper border of sacroiliac joint, and middle ureter from upper border to lower border of sacroiliac joint, and lower ureter below the lower border of sacroiliac joint.
A small stone in middle ureter may be difficult to locate due to underlying sacrum. This may be evident on CT or IVU because of proximal hydroureteronephrosis. Any ureteric stone longer than 5 cm or weighing more than 50 grams is called giant ureteric calculus. This is retained barium due to anal stricture, very much simulating a large bladder stone. In such cases, rectal examination, ultrasound, and on-table scopy are mandatory before opening bladder.
I have found squamous cell carcinoma associated with large stones. So it's mandatory in our unit to have a scopy before opening for a large stone. Now, there are some patients whom you can't do rectal examination.
This is a stone in an ileal conduit. Some workers have used Xray KUB to exactly tailor the size of transvaginal mesh for treating pelvic organ prolapse. The preferred terminology is intravenous urogram or excretory IVU. However, the word IVP is still used, but it's a misnomer because it denotes pyelogram, means visualization of only PCS. Nowadays, the cross-sectional imaging has largely replaced IVU, but it is still widely used because it allows visualization of the whole ureteric tract, its availability, low cost, and much less radiation. Indications of IVU: visualization of urinary tract, for example, in congenital anomalies, to evaluate the level of ureteral obstruction, intra-visualization in ESWL or TCNL. In renal trauma cases, one-shot IVU is done to ascertain that opposite kidney is there and it's functioning, and in some special circumstances like ptosis, transureteral ureteroscopy. Limitations: it doesn't pick up pathologies outside urinary tract because it's not a cross-sectional study, doesn't differentiate solid from cystic lesion, doesn't allow visualization of small and radiolucent stones. The quality may be limited by inadequate bowel preparation and requires a long filming sequence. Contraindications include deranged renal function, pathogenic syndrome, allergies, multiple myeloma, infancy, diabetes with renal failure, thyrotoxicosis, and pregnancy.
cutoff value of serum creatinine for this study is 1.78 milligram percent with no risk factor and 1.68 milligram percent with diabetes. IVU should not be done during colic because the affected unit will not be visualized. Now let's see the radiation hazards associated with these investigations and comparison among them. Radiation doses to human body are depicted in millisieverts. You can see the comparative values. For Xray KUB it is 0.2, for IVU it is 1 to 10, and for contrast CT or whole body PET it is 10 to 100, and the annual permitted limit is only 50. Any person working in these hazardous areas should wear TL devices and monitor their exposures. Is it not shocking to note that 1 in 1,000 individuals affected by 10 millisieverts may develop malignancy, whereas single CT can expose up to 100 millisieverts. Thereafter, treatment by PCNL in stone disease, another 50 to 100 millisieverts. This picture on right side shows body effects with increasing radiation dose, and on left side, different parts of body affected by radiation. Preparation for IVU is same as that for plain X-ray, except that patient should be fasting for 4 to 6 hours to prevent aspiration of vomitus. Patient should be well hydrated to reduce contrast-induced nephropathy. The value of N-acetylcysteine is controversial in such patients, and if there is pre-existing renal failure, metformin should be withdrawn for 48 hours. Apart from this, the investigations requiring contrast media should be very well spaced and with the use of iso-osmolar contrast media. With availability of non-ionic contrast media, the adverse reactions and mortality have significantly reduced, and iso-osmolar contrasts are safer in high-risk cases. Sometimes the contrast media are excreted by extrarenal routes, for example, liver, gallbladder, bowel, tears, gastric juice, etc. In this case, you can very well see that contrast is being excreted by gallbladder and rectum. This slide shows adverse reactions to contrast media divided into 3 categories: mild, moderate, and severe. Availability of non-ionic contrast media, the mortality rate has come down from 1 in 1.7 lakhs to roughly 1 in 5 lakhs. As previously discussed, the use and contraindications of abdominal winder. It is used during IVU for better delineation of ureters in their entire length. This slide shows sequencing of IVP films. Nephrogram can be divided in 2 phases. Vascular nephrogram persists for 10 to 14 seconds and it disappears and is followed by much denser excretory or tubular nephrogram which appears at 1 minute and lasts longer. This IV film taken at 9 hours still shows persistent nephrogram on left side, suggestive of acute ureteral obstruction.
Now you can see from nephrogram phase at 5 minutes, contrast has started appearing in the pelvic system. This excretory phase shows both kidney contour and contrast filling the pelvic system. This is a film taken immediately after release of binder, showing both ureters in their entire length. Some radiologists, instead of binder, use prone film for better ureteral visualization and drainage because this position displaces viscera towards periphery. This picture shows ureteral jet from right ureteric orifice. Histogram phase at 45 minutes shows bladder size, contour, any filling defect, diverticula, or prostate indentation. Post-void film shows the amount of residual urine. Apart from residual urine, post-void film also better delineates bladder diverticula, and also evident in this film that this diverticula causes medial deviation of lower ureter. IVU in routine is done in supine position. However, erect film may better delineate layering in cases of emphysematous cystitis or milk of calcium in diverticula. Nephrotosis is best shown in erect IVU as this posture is not possible in CT or MR. In intermittent or equivocal nature of UPJ obstruction, a diuretic challenge may precipitate typical UPJ obstruction in a patient where symptoms are persistent and previous IVU is normal. One shot IVU is performed by giving contrast 2 ml per kg body weight and taking a film at 10 minutes.
You see, this is a real emergency in a patient with blunt or penetrating trauma with shock immediately taken to OT, and this bulb film shows that the left kidney is present and it's normally functioning because most of these cases on exploration result into nephrectomy.
Infusion pyelogram is obsolete and no more considered nowadays. This film shows persistence of fetal lobulations in adulthood. This shows dromedary hump in left kidney due to pressure effect of spleen. IVU is an investigation of choice in patient suspected to have nephrotosis. IVU is still commonly performed in urolithiasis. The branching of a staghorn calculus matches the antlers of a stag, hence the name. This slide shows staghorn and partial staghorn calculi. 2 IVU films showing calculi in calyceal diverticula. IVU in a patient with bilateral renal and vesical calculi. Right hydroureteronephrosis due to upper ureteric calculus. Let's have a look at congenital diseases. UPJ obstruction has characteristic cutoff at UPJ with persistence of contrast in pelvic system. ureter is either not visualized or it is of normal caliber. There may be high insertion of ureter. The degree of hydronephrosis may be variable with cortical rim sign in cases of severe hydronephrosis. UPJ obstruction, when associated with a crossing vessel, is characterized by a gap between pelvis and ureter. Classical left UPJ obstruction with severe hydronephrosis. UPJ obstruction is associated with renal calculi in 20% cases. Here, UPJ obstruction on left side is associated with multifaceted secondary calculi. Left UPJ obstruction with secondary stones. Bilateral UPJ obstruction with severe hydronephrosis mimicking the balloon on a string sign. Cortical rim sign on right side in the case of severe hydronephrosis. Cases like this, UPJ obstruction with stone, PCNL should be done first, followed by drainage studies to document obstruction. This slide shows various grades of hydronephrosis. This IV film shows classical features of a retrocable ureter. Another film showing retrocable ureter resulting from embryological maldevelopment of IVC. In retrocable ureter, sometimes ureter passes between bifid IVC, a condition called transcaval ureter.
And this may be a surprise on table because many times this may not be even evident even on cross-sectional images. IV in a patient with horseshoe kidney and bilateral UPJ obstruction. Horseshoe kidney with typical flower base appearance. Horseshoe kidney with a classical handshake sign. IV in a patient with bilateral complete duplex system and cystoscopy film on right side showing Wegertmeyer rule. This is an IV in duplication, and duplication is one of the causes of enlarged kidney. UPJ obstruction in lower moiety on right side. Duplication with left severe upper pole hydronephrosis is seen as upper pole cortical cyst in USG and drooping lily sign on IVU. MCU in this case is normal and he required upper pole moiety excision. In duplex system, lower moiety hydroureteronephrosis is often the result of reflux. The upper moiety usually gets obstructed. It may be ectopic, it may be part of uretocele, and the lower moiety often refluxes.
This shows left side duplication with upper moiety ureter forming ureterocele. Upper pole hydronephrosis in duplex system displaces lower moiety downwards, mimicking drooping lily. Right upper moiety opening into vagina in a girl presenting with urinary incontinence
with normal voiding. A close-up view of an ectopic ureter opening into left seminal vesical cyst. Right solitary kidney with ectopic opening into vestibule could be cannulated and RGP performed. Left side film shows bilateral orthotopic uretocele and right side film shows right-sided orthotopic uretocele. Sorry, it's left-sided uretocele. Typical cobra head appearance from bilateral orthotopic uretoceles. If kidney is not visualized on IV, it should be reported as non-visualized kidney, which may result from agenesis, poor function, prior nephrectomy, or simply study being done during colic. It should never be conclusive of agenesis or absence. In cases of agenesis, one should look for contralateral compensatory hypertrophy, UPJ obstruction, primary megaureter, or vesico-ureteric reflux. Spider leg appearance caused by multiple cysts in a case of autosomal dominant polycystic kidney disease. Multiple radiolucencies in the nephrogram produce characteristic Swiss cheese appearance. This film shows classical features of medullary cystic disease. The contrast in the dilated ducts produces paintbrush appearance. Contrast in dilated collecting ducts produces a characteristic bouquet of flowers appearance in medullary sponge kidney. A characteristic beak in distal ureter is diagnostic of primary megaureter. Another case of left-sided primary megaureter. Ectopic kidneys are often seat of infection, hydronephrosis, or stone disease. However, in this patient, right-sided pelvic kidney is normal. Fusion of both kidneys producing typical pancake kidney. A soft tissue shadow in right lower chest proved to be intrathoracic kidney on further imaging. Left malrotated and ectopic kidney. I view showing left side severe hydronephrosis with reverse centration and right side film RGP shows lateral insertion of ureter. This is left crossed fused ectopia because the left ureter is inserted into bladder on left side. This film shows right pelvic kidney. I view in a patient with VF showing leakage of contrast into vagina. This IV film shows leakage of contrast in pelvis with right hydroureteronephrosis suggestive of right ureterovaginal fistula. Plain film in a patient with prune belly syndrome showing bulging of flanks due to absence of
abdominal musculature. This is an eye view in a patient with Prune Valley syndrome. The aim here is to preserve renal function. Cystogram in a 10-year-old child presenting with recurrent febrile UTI shows bilateral H diverticula. The film on right side is MCU showing bilateral vesicuretic reflux. And this patient required diverticulectomy and bilateral ureteric reimplantation. Multiple small secondary diverticula in a patient with neurogenic bladder. This IV film shows multiple strictures at the level of renal pelvis and distal ureter due to genitourinary tuberculosis. This slide shows possible lesions right from kidney to urethra in genitourinary tuberculosis. Bilateral phantom calyx in a patient with GUTV. Mouth-eaten calyx due to tuberculosis. Central papillary necrosis in a patient with tuberculosis. Parenchymal calcification at the lower pole due to tuberculosis.
Now, this, despite anti-tubercular therapy, increasing parenchymal calcification is an indication for partial nephrectomy.
Renal tuberculosis causing cortical scarring. Asymmetric scarring of pelvis causing hiked up pelvis, also known as cat's kink. Plain film showing speckled calcification on bladder wall. Thimble bladder in a patient with tuberculosis. Irregular bladder contour due to tuberculosis cystitis. Left hydroureteronephrosis due to lower ureteric stricture from tuberculosis. Multiple ureteral strictures seen on IVU and RGP in a patient with GUTV. Left nephrocholic fistula due to tuberculosis.
This nephrocholic fistula is more common in pyogenic conditions than tuberculosis.
Massive lymph node calcification in a patient with tuberculosis involving both pelvic and retroperitoneal lymph node. Photonephrectomy in a patient with tuberculosis. Tubercular calcification of prostate. Left-sided emphysematous pyelonephritis. Right emphysematous pyelonephritis. Intramural gas in bladder wall in a case of emphysematous cystitis. In emphysematous cystitis, there can be a combination of intramural and intraluminal gas. Intramural and intraluminal gas in emphysematous cystitis may be present alone or in combination.
Now here you see in the erect posture, there is layering of intraluminal gas. In this film, you can very well appreciate the intramural gas distinct from intraluminal gas.
Hiated cyst of left kidney. Right-sided staghorn calculus with non-function in a patient due to gastro-gastroenteritis pyelonephritis. IVU in a patient with staph injury showing extravasation from upper ureter. Papillary necrosis producing egg in cup or wolf ball on T appearance. Medial deviation of middle ureters producing maiden west sign in retroperitoneal fibrosis. Filling defect in left upper ureter, which on RGP produces a typical goblet sign. Bilateral vesicular junction obstruction, small capacity bladder, prompt ketamine abuse.
This is quite common in Western countries, but rarely it has been reported from other parts of the world also. And it is easily mistaken for GU2E because of high prevalence of tuberculosis in our country.
Filling defect in left renal pelvis
I found this on the web for
congenital cell carcinoma. IVU is an investigation of choice in a patient with transuretral.
Another point in these cases, in transureterostomy, there can be reflux from one moiety to other, and this is known as yo-yo reflex.
Patient with radical cystectomy and ILL conduit presented with right-sided symptomatic hydronephrosis on CT, and on nephrostogram it shows right ureteroileal stricture.
And he required revision of the anastomosis.
IVU in a patient after mitrophenol procedure. Cystogram in a patient with augmented bladder. Allograft with hydronephrosis due to ureteral stricture with PCN in situ. Cystogram in a patient with sausage and bowel flap.
Because of the non-refluxing anastomosis here, you can see reflux into the pelvic-calyceal system.
Physiological herniation of bladder into bilateral still incompetent internal rings.
This is typically seen in children on IVU and never seen on MCU. And it's physiological, it disappears after 5 to 7 years.
Bladder herniation into right inguinal hernia. Massive intravesical enlargement of prostate. Chronic retention of urine causing bilateral hydroureteral. Massive intravesical enlargement of prostate causing medial and cephalad deviation of both ureteric orifices, producing typical fish hook or hockey stick sign. Leiomyosarcoma of prostate, shifting bladder upwards. Bilateral endometriosis causing bilateral lower ureteric strictures and hydroureteral nephrosis. The scout film should be reported with the name, date, position, exposure, bowel preparation, soft tissue shadows, bony shadows, and abnormal radiopaque shadows.
Now for a sample, I am showing you one Xray KUB, and this is how you should report it.
This is Xray KUB of Mr. X done on 14 July 2019. Position is incomplete in both cephalic and caudal direction. Exposure is adequate. Wall preparation is not good. Soft tissue shadows visible are left kidney, bilateral source, and bladder. This is Xray KUB of Mr. X done on 14 July 2019. Position is incomplete in both cephalic and caudal direction. Exposure is adequate. Wall preparation is not good. Soft tissue shadows visible are left kidney, bilateral source, and bladder. Bony shadows are normal, and there is no abnormal radiopaque shadow suggestive of calculus. Now, in all the patients, one should always look in the intersulpicial space for any calculus.
And the IBP film should be reported with description of nephrogram, pyelogram, renal size, shape, and axis, any mass lesion, dilatation or filling defect in the pelvic ileal system, course of ureters, hydronephrosis or any filling defect, bladder size, shape, contour, diverticula or any space occupying lesion, and residual urine in the post-void film. And finally, the conclusion should be given. I'm giving you a sample.
3-minute film shows bilateral dense nephrogram. 5-minute film shows prompt excretion of contrast in pelvic ileal system. 15-minute film shows bilateral PCS, ureters, and bladder. Following administration of 45-minute film shows well outlined bladder, no filling defect, and the post-void film shows excretion of contrast by both the kidneys and minimal post-void residual urine.
So thank you very much. With this conclude.
Xray KUB of Mr. Ram done on 15th March 2020. Position incomplete in both caudal and cephalic directions. Exposure adequate. Wall preparation is okay. Soft tissue shadows, left kidney, bilateral soft shadows, and bladder are seen. Bony shadows are normal. There is an abnormal radiopaque shadow visible in left renal area, suggestive of left renal calculus. There is an artifact on right side, which is not visible in other films. Post-contrast 3-minute film shows bilateral dense nephrogram. 5-minute film shows prompt excretion of contrast by both the kidneys. Kidneys are normal in size, shape, and position. There is no obvious mass lesion seen. The abnormal radiopaque shadow produces a filling defect in left renal pelvis. 15-minute film shows bilateral PCS without any dilatation and a stone causing filling defect in pelvis. 30-minute film shows bilateral upper uterus without any abnormalities and contrast starts appearing in bladder. 45-minute film shows normal bladder in size and shape. 60-minute film shows complete excretion of contrast from right kidney. Left PCS is still seen. with a stone shadow and normally outlined urinary bladder. Postword film shows insignificant residual urine. So the conclusion is left renal calculus in renal pelvis with bilateral normally visualized kidneys having prompt excretion of contrast.
So with this we conclude. Thank you very much.